Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging at Memorial Sloan Kettering Cancer Center, and I'm also Vice Chair of Education, and I'm a Professor of Radiology at Cornell Medical College in New York. What is the role of imaging in patients treated with immunotherapy? Radiologists evaluate the response of treatment with immunotherapy on imaging. We use several criteria. We use RECIST, which is the response evaluation criteria in solid tumors. And then we also use the iRECIST, which is a specific response criteria used for immune therapy. So the major item that radiologists identify is the response of treatment. Secondly, we also look for toxicity and any specific complications from the treatment. So when we use response assessment, we use the iRECIST or RECIST 1.1 guideline. The iRECIST takes into account distinctive responses linked to these types of treatments, such as delayed response after pseudoprogression. That occurs in a small percent, less than 10%. But due to the immune therapy, this lesion may actually increase in size. And it's not an increase in the tumor per se, but rather it's an inflammatory reaction from the infiltration of T cells into the tumors. Therefore, the tumors look larger. And that definitely makes it difficult to assess whether it's increase in actual tumor size or is it pseudo progression. So if a new lesion also arises, again, that could be because it was previously occult, and now due to this inflammatory reaction, we see this lesion. And in iRECIST, what we also do, we follow the lesion, and subsequently it should be decreasing or disappearing. So if we see that, then we know that this was pseudo progression. Now, there's no reliable way to differentiate pseudoprogression from true progression just on plain imaging. And that's why we use short-term imaging follow-up to see whether the increase in the tumor burden was just transient. Now, unfortunately, in the vast majority of patients, an increase in tumor volume or in the number of lesions generally represents true progression. But that's what's unique about immune therapy, that you could have pseudoprogression. Now, other things we can look for is the actual attenuation of the tumor. Sometimes these tumor with treatment may become more necrotic and have different densities. That's not taken into account with the traditional RECIST criteria, but is something that we could also assess on imaging. Also, very importantly, with immunotherapy are the adverse effects and the specific types of toxic effects seen from immune-mediated treatment. And in thoracic aspects, we can include a pneumonitis and also sarcoid-like reaction, which represents increase in lymph nodes due to enlargement and a sarcoid-like reaction per se. The inflammation from this immune-mediated response could also lead to enlargement of the thyroid, which is thyroiditis, or tracheitis, which is inflammation of the trachea, or myocarditis, inflammation of the myocardium. So these are all things that radiologists would identify on imaging and would raise the suspicion to the referring physician. We can also see in extrathoracic complications such as pancreatitis, which is inflammation of the pancreas, inflammation of the colon, such as a colitis, or even inflammation of the joints like an arthritis. So these are all things that a radiologist would identify. Now, what about PET-CT? It does have the potential utility as a predictive biomarker in patients receiving immunotherapy, and perhaps the ability to assess tumor response and to identify patients who are more likely to respond to treatment. But currently, this is still just investigational. So it has not been proven to do that, but hopefully may be one day useful in that sense. It can also help as far as identifying areas of inflammation like an arthritis or a sarcoid-like reaction. But generally, most of those findings are seen on CT imaging alone.